We want to get your feedback on the papers and the thoughts from the morning. It was a pretty rich set of papers. I've heard a lot of good comments about it. I think there's a lot of, it's pretty clear the world is changing and that has a lot of implications for what we're doing. I think that was a good little shot of energy for folks to think that actually there is a world out there that's going to be interested in some of the ways we think. So gather around. We're going to start. Russell Glasgow is going to be the moderator for this set of the feedback from the tables. And Russ is the deputy director now at NCI. You all know Russ from REAIM. And as I said in another forum, he's a straight shooter. That's a little postprandial joke. Russell Glasgow is a Deputy Director, Dissemination and Implementation Science in the Division of Cancer Control and Population Sciences at NCI, where he provides leadership on numerous research projects to close the gap between research discovery and program delivery in public health, clinical practice, and health policy. Dr. Glasgow specializes in the design and evaluation of practical and generalizable behavior change interventions, especially using interactive technologies for use in healthcare, worksite, and community settings. He earned his PhD and his master's degrees in clinical psychology from the University of Oregon in Eugene. And as I said, we're happy to have him with his experience at NCI, and we look forward to his moderation.
Thank you so much, Steve. But just for the record, two things. Moderation is usually not one of the things that I get charged with. And second, just for the record, even though I am a straight shooter, I was not down at the thing where you shoot all the automatic weapons that they have out in town. Okay, this is your chance now, folks, and this is our last public forum anyway here. We'll love to have your written feedback all throughout, but to counteract the inevitable slump and postprandial depression that Steve mentioned, I want you to start exercising by lining up now to get up to the various microphones around here. This is not only your discussion point and opportunity from the session 3 papers, but also from cross-cutting things. You know, those things that you've just had the aha where you're having lunch about, that how it all came together for you. We need to hear those. We do have a couple of ground rules, though. Rule number 1 is we really need to hear from everybody. So at some time during these next 50 minutes now that we have, I'd really like to hear from each table, at least one thing from each table. In order for that to happen, if you do the math, you'll be pretty able to figure out that we're going to have to be brief. So I'm going to ask you to keep your question or your comment to no more than 1 minute. If you will, when you come up, so we can hear from the others and see if there is emerging consensus or not. As you're starting to line up now, so this is any comments and key things that evolved from your table in session 3, or any cross-cutting things you have. So please start lining up, but just to warm you up, I anticipated this might happen, so please, we need you to come on down now, folks. We don't have any bingo things. I'm going to just put up a couple of things while you're lining up at the various mics here that I heard throughout here that I think might be questions that issues you might want to weigh in on. And I'm not going to read these, but what I am going to do is subliminally, I'm going to cycle through these during the next 40 minutes just to see if there's anything that catches with you. In order to provoke a little bit, I might point your attention to maybe the issue, a question about policy, and the one about the consumer, citizen, patient level. Second, I thought some things that I heard this morning were provocative, were unanticipated, unpredictable outcomes. We haven't heard much at all about framing of issues, even though a lot of speakers implied that this is a critical issue when we start dealing with the political and the larger spheres. But how do we frame issues, health communication science issues, and finally, a quick warning, I am going to call out some people if you don't volunteer. So here's among the ones, we reserve the right up here to call others of you out, but here's a little early warning. If you see your name here, you might be prepared to gather some thoughts. And with that, let's just go back and open the floor. Xinping.
I think I did too. Xinping Tu from the University of Washington in Seattle. And I am representing Table 17, which was really excited about the opportunities for potential big science at this stage with healthcare reform, etc. And I think in particular, Table 17 was really looking forward to a paradigm shift, especially with respect to the opportunities for natural experiments, as well as existing and hopefully additional information platforms to collect data where you can then have information for smaller studies. So that was our first comment, and we would love to hear more about that. The second is regarding the genomic component. I think our table had a lot of healthcare providers as well as public health providers. And we really felt that it would be important to have the population health benefit incorporated into that consideration regarding how to move forward on the genomic front of healthcare. And we thought that Dr. Warnicki's work regarding the elegant disentanglement of variables and how to be able to have funding mechanisms that incorporate and further enable those types of work would be really, really essential.
Thank you very much. Again, just under a minute, so that was great. I'm also going to ask the panelists up here to also please be very concise, and I will try to exercise or let you know if you're going on, to also keep comments. And I'm also going to, unless there's something that I'll let you override me, but unless it's really, really burning, I'd like to try and reserve the responses to either one or at most two people. I don't know we need 4 talking heads that say, I agree with everything. So is there anybody that would like to take that one? And in the future, if you do have your question, if you could begin by saying if it's directed to one or more of the authors or the presenters, if you could start out with them just to give them a heads up. But is there anybody, I thank you for those comments and they're duly noted. Is there anybody that would like to reply to any of the Xinping's comments?
Can you give us a shot at the end?
Of course, we'll do that. Yep. Win.
So since genomics was mentioned, I'm happy to kick off. So I agree with the comments that were made, and especially vis-a-vis the idea of conceptualizing genomics from a population health benefit angle, because I think that's been not too much in the discourse. It has been traditionally driven by technology. The more sequencing do the assumptions is that the more we do, the cheaper it gets, the better it will be, rather than starting from the pull forces of whether or not this actually can work to improve health outcomes. And that's a population level perspective. So I agree with that being somehow integrated into the discourse. And so thank you for your comment.
Okay, and thank you. One thing that came up at our table, I know, was that Nguyen's paper, I think, pointed out more sharply, maybe, than some of the others, the potential for harms and waste also, which is a huge issue that somebody might want to follow up on. Deb?
Deb Bowen from Boston University. Perhaps this is a little bit, this refers a little bit to yesterday's conversations as well, but I'll try it now. One tension that we noticed was between the idea of health and the idea of health care. So health care is in the title of our conference, and yet several of the presenters brought up examples and data and models that were from other than health care. And so we struggled a little bit with the role of health care in, say, an onion, or even a pyramid, perhaps, of interventions. I mean, is healthcare a level, or is it a goal? Is it both, depending on how you look at it? And are you, the folks who are writing these papers, looking at healthcare as how exactly? It ties into the definition of level that sometimes over the papers perhaps got away from us a little bit, that there might be some need to have a little bit of consensus about, and a very specific comment about level. When one defines an MLI, why does an individual intervention, why is it required that individual intervention and or individual outcome be a part of an MLI? Why is that? What was the thinking behind that decision? Many folks at the table yesterday and today came up with examples from the literature, from their own or of MLIs, things that might qualify as an MLI that had neither an individual intervention component or an individual intervention outcome, because they lean on the data that had been collected before. So just a thought, you so clearly define individual as part. Certainly it is, but why the definition of MLI?
Okay, I'm going to let Steve take the first shot at that, and then Dick. So if we can, we'll refuse it to two. But just to try and paraphrase, and Deb, you might want to stay there. We might have chance just for a very, very quick back and forth, depending on what happens here. We're all going to try and be quiet. I'd say this is the first kind of provocative issue that we've had since I'm here, which is great. But I heard, is healthcare a level? Okay, or is it, something, the definition of the whole thing there? I also heard maybe a challenge to the definition of the onion. How is it? Or a friendly comment or question for clarification on that. So Steve first and then Dick.
Okay, well, I just want to comment on the individual intervention outcome thing, because I think one thing that I mentioned in my presentation, and also Steve mentioned early on, is that there was a real focus in terms of our interest in doing this, that the ultimate thing we're trying to drive is patient outcomes. Okay, and it's not necessarily that every single element of that knowledge stream has to have an outcome as part of that intervention stream, but there must be some kind of framework in which there's an expectation that it's going to be tied to ultimately deliver something that's going to improve the ultimate experience of care. And it doesn't necessarily always mean in cancer terms survival. There's other kinds of outcomes that we've tried to acknowledge in terms of the thing. And I think you're right, some of those outcomes that get into the quality of life domains and some of those other things, you have to think about whether you're talking about health or healthcare. But largely we are trying to focus our attention right now on those things that drive patient outcomes as part of those care processes.
Two things. I would call healthcare a mechanism under Steve Taplin's definition. It's something that happens between levels. I may have taken his point wrong, but that's what I would call it. It's something that it's an action rather than.
I know. No, I think that's why I asked Deb to stay here. And as Steve's coming up, or go ahead and finish your point.
I just
Dick,
have another thing.
But I want to just give Deb a quick chance to respond. Then we're going to have Steve. But I also don't want to lose point of one other thing that Deb alluded to when she talked about a triangle as opposed to an onion, or maybe compatible with onion. I think what she's alluding to, Deb, I don't want to put words in your mouth, was the Frieden type triangle, the CDC triangle, and that. So we might want to, somebody else might want to address that.
I just want to finish.
So finish yours, and then Steve, and then Wynn.
The other thing is that, of course, from the perspective that I come from, which is disparities, there are no individual issues. There are differences between groups and populations that affect individuals, but the focus really is on resolving the differences at that level. So
I'd just reinforce Steve's comment that the focus of this effort has really been about healthcare, and that's why healthcare was in the title. The issue of the process of care is individuals are there and providers are there, and so process is simply a way of manifesting the effects of these levels on the healthcare team or the healthcare individual or the healthcare provider. So we see the process as just a location in which the effects are manifest. So I don't see process as a separate level in the way that I'm thinking. We did talk about individual patients, we did talk about providers and provider teams. Those are all involved in different parts of the process of care.
I mean, I think it's interesting that, I'm forgetting which person brought this comment up, maybe a couple folks, that much of our evidence for any sort of multi-level effort, it comes from primary and secondary prevention as a topic. And in that sense, again, we're not always talking about patients, we're talking about people, or individuals, or entities, or groups of people. So maybe at least one thing that the papers could do is, as they bring in examples outside of the patient-provider healthcare system arena, to help the readers kind of grasp what those differences are.
That's a good point.
I'm not really in some of the papers. Our table talked about this and didn't maybe follow everyone as well as they could have.
And it's certainly true that you can have three levels anywhere, and they don't have to end up with the individual. So that's perfectly fine. We just chose to make sure that we tried to drive it to the individual.
The tobacco work, where when we look at state tobacco sales as an outcome, we could probably, folks have generated multi-level interventions to change state tobacco consumption levels, not measuring anything about an individual's cessation habits, so we count that as a multi-level intervention, and it gives us great ideas for future.
I think that's all completely appropriate, but as Steve was saying, we focused on the individual patient outcomes.
Okay, Muin in just a second, and I'd like to take the prerogative of the chair to invite, if there's anybody from the audience, I want to let this go just a little longer because we're starting to have fun now. So if there's anybody that is directly going to comment on this, I'm going to give you priority to come to the microphone directly on this particular issue. But I will comment, there's one other thing up here that kind of relates to that. If the third one down here, if anybody wants to talk to that about the terminology used about consumer, citizen, patient, and that how that interacts, particularly with electronic health information issues and things as well. But with that, Nguyen.
So, Deb, thank you for your comment. The issue of the onion versus the pyramid also came up yesterday in Group 7, where I was at that table. So, for those of you who may or who don't know this, the CDC director last year published a paper in the American Journal of Public Health about the health impact pyramid, in which he postulated there are 5 levels of intervention. And at the lowest level is interventions that fight poverty and education, increase education, which we normally don't think of them as clinical or even public health intervention. The second level is the policy work, which is what he calls changing the context, meaning tobacco excise tax or putting fluoride in the water or whatever. The third level is the clinical intervention, which is the the third level is public health programs like newborn screening. When you think about genetics, something that public health departments do. The fourth level is clinical interventions. That's where the process of healthcare goes. And the top of the pyramid is health education. And it reflects the bias of the CDC director that as you go to the top of the pyramid, the impact becomes lower. As you go down to the bottom of the pyramid, the impact would be larger on the number of people affected, and therefore policy change for him actually supersedes health education. And he postulated that you can attack any problem from multiple levels of intervention, both from a clinical and a public health perspective, including healthcare delivery. So just to put a bit more of salt and pepper on this, when the Lynch syndrome recommendation came out last year from the EGAT working group.
Quickly, Marin, right?
Yeah.
Okay.
So we had an implementation panel that discussed how we're going to implement it from multiple levels. And I forced them to think through the onion, and I forced them to think through the pyramid. They liked the pyramid a little bit more than the onion because it provided different tools that are not all in the clinical domain, but outside the clinical domain, but it doesn't matter. So I agree, healthcare is part of the health continuum, and you can attack the problem from multiple other perspectives.
Okay, so I heard a couple of cross-mega level type issues that the authors of the paper might want to keep in mind. I believe these two are both directly related to the issue, so go ahead, Mike, and then over here.
Yes, it's good you spoke, because I was going to speak to your genomic medicine presentation, but by way of saying that I was at the table with Deb and another person here, and I came here as a person interested in rural health care and systems. And my focus as of late has been on networks, rural health networks. And so I was very happy to be here, and I have all of the focus on individual patient. But my sense of multi-level analysis is more like making the rural health network the level of interest. And I might look at 2 or more levels above, or 1 above and 1 below. So I was extremely interested in that, so I thought, well, it would have been nicer to be broader. Well, this morning, and looking at the genomic medicine presentation, 2 things came to mind. A colleague from the table here yesterday said that the levels that we started out with didn't have, and these are my words, biochemical, biocellular, physical. So you fit that in. But what struck me from Dr. Scott's presentation is that you showed a lot of steps, like a kind of series of steps to kind of get it all in place. And it occurred to me that a multi-level intervention approach might be a good one to help along those steps.
Okay, one person respond, and again, we're having great discussion, but we're not following the 1 minute rule, so when it was kind of most directly at you, but if somebody else is more passionate, I'll let them go ahead. You got it.
I think you're referring to the T1 to T4 framework. Where do you go? That sort of and that, this was not designed by me or anything. This is sort of the two phases of translation by the IOM, and it applies to any field. It doesn't really apply to genomics in particular. I was trying to understand the landscape of translation when it came to genomics, so that's why I wrote those papers. But it can also apply to everything else we do. And I think, Russ, you have been thinking along the same lines as well.
We have been scheming on that. I'm going to just, without any explanation, do a little subliminal image here as we take the next comment on this, maybe an additional way. But the meta issue that I heard here is, are these levels fixed? Is there a right number, 6 or 7 or whatever, or is that an adaptive learning process too? And that when we're focusing on, for example, rural health, or maybe we're talking about indigenous communities or something, do we adapt the levels, keep the same principles or not? And we got a response from Martin, and then I will get to you, sir.
So I think that the example that I cited in the Yano et al. Paper would argue that the levels are not fixed, and in that study they had to look internally within the organization for multiple levels, and in other places you may not. So at least that's my take on it. Within a minute.
And is Dr. Scott still here today or not from his talk yesterday? I was just wondering about his take on that. I'm thinking from what I heard, I'm not familiar with the work, that he might concur with that, and that you look at for the political points and things. So,
Mary.
He is? Oh, go ahead.
I actually wanted to comment on that third bullet related to the terminology we use to discuss whether it's a patient or a consumer or a citizen. And I actually wanted to push it even a bit further based on discussion that we had at our table. And I was prompted by Dr. Clauser's, message that we really hadn't talked about the role of individuals except as sort of the target of all of our work. And I, as a person who's studied community psychology and empowerment models a great deal, I actually think we need to think about one outcome of our work, not only as healthier people, but as empowered people and as empowered consumers. And I don't mean that just as a rhetoric, that I actually think that by empowering the patients, consumers, citizens that we work with to be very influential in their care, either by shopping with their feet, by directing where their dollars go, by sharing information with one another about where they can get good health care, where the health care is not so good, that we can begin to help foster organizational and policy level changes. In our discussion, I said, I wonder how many people really understand the statistics that were presented yesterday about the quality of healthcare in the United States. And if we were to empower consumers to know that if you're shopping for cancer care or whatever, that 50% of the time, roughly, you're likely to run into substandard care in your community with a doctor who seems very nice at the hospital that seems very friendly and familiar. So I sort of half facetiously said that we need to be running interventions that contribute to medical mistrust, at least empowering people to know what they're getting into. And I will say that the last thing is that this 17-year cycle of getting innovation into practice is I think we can counter that by saying that every contact that we have in community-based interventions or organizational interventions empowers consumers, that we can do that without FDA approval and without years of churning through a system, that we always be about helping people take more control of their care.
Okay, thank you. this kind of great discussion that we want. It also brought up some issues related to the second point here, maybe about framing issues and how we understand or don't understand issues, at framing them at the different level. And I'm going to allow one more response here from the panel, if anybody wants to say anything about that, and then we'll move on to, I think, to a new, are we kind of reaching 90% on this anyway? And you're going to go way back. Okay, so we're moving on, new topics. So come on up for new topics, different areas.
Hi, I'm Mary Stepp from Case Western Reserve University, representing Table 15. And we had a series of wonderful conversations, and I think we're all very enthusiastic about exploring this idea and applying these ideas to our own work. However, we kept, with each conversation, we kept coming back to the idea of what really is a multi-level intervention, and this fundamental idea of what are the levels and what kinds of interventions count. And although we all agree that this is not the time to be prescriptive about these things, we wanted to express our hope that this learned community that literally brings to the table some many perspectives on this work, that we can capture a little bit of lightning in a bottle, and with these upcoming publications, offer some guidance to those of us who are setting out and want to do these designs. We've talked about what makes interventions, why these MLIs fail, what's a proper MLI, what are the strategies for MLI, but some of the fundamental criteria are very important to us. And what really clued us into this was perhaps a throwaway comment that many of the posters weren't really multi-level interventions, and that really stuck with us. And that, although we'd like to talk about all these different things, we're hoping that you could provide some guidance as to then what is. Because if we want to respond to calls or RFAs or whatever's going to exist after this, we need some guidance.
Steve. I was going to say, and part of the issue is, again, trying to get clarity over, interventions, at least, more than one, right? At least more than one level, whether it be patient, provider, organization. And I think it is a conundrum because we can, within each one of those bands is a lot of space. At the organizational level, you probably could make a case that there are many levels. One could intervene within the context of the organization. And this is the first step for us to begin this dialogue to try to clarify how these sorts of things play out in different types of studies. But I think one of the things we've talked about, that it was fairly clear, at least from our literature search, that we're still, it'd be great if we could argue whether studies that had 2 or 3 or 4 interventions were actually multi-level or not. We're still single level, single target. So we've got a long way to go, I think, to even have that kind of conversation. And that's what we're trying to engage here in this work.
Oh yeah, we get that. I'm just wondering why those posters were not considered multi-level intervention.
Okay, Dick.
Well, I didn't judge the posters, but on the more general issue of multi-level, I think that's why it's so much emphasis in this conference has been on conceptualization of the problem. And it's one thing to answer a direct hypothesis about individuals. It's another thing, as it is in disparities. Again, I'll go back to my own model, where you know that there are different things that intervene before the patient even gets into the system, and when the patient gets into the system, may end up in the wrong system or getting the wrong care. So it's a conceptual framework that you have to work with, and if you want multi-level research, then you have to consider what are the levels of intervening variables, not just intervening variables at one level, but intervening variables at other levels.
Okay, I don't know if Becky's still here or not. I don't see her right now, but I thought she made an important point earlier related to this too, which was the fact that many interventions, and we've had the minor sub-discussion of this about a patient-provider intervention. Is that 1 or 2 or 3 or how many is that? But I thought Becky made a pretty profound point that, and it might illustrate or benefit from an illustration, that many things that we even call single level are frankly probably intentionally or unintentionally multiple level interventions, and often can produce outcomes at other levels, again, intended or unintended, positive or negative too. I don't see Becky here, but we're over half our time, and I do want to have a specific call out here. And if some of you note here, I particularly want to call out, I'm going to let these two individuals go, but I want to invite those whose names are here to come up and comment on some of these issues, but I also do want to throw out the combination of the Don Berwick Challenge to ask, what are you going to do? In addition to telling us at NCI, what can we do for you? What can you do by next Tuesday to start making this happen, making it real, to advancing the science? And if your table has not commented yet, I really want your table, I want to hear from each of the tables to come up here.
Hi, I'm Linda Fleischer, Fox Chase Cancer Center. Our esteemed leader, Ron Myers, left, so I get to speak for our table 10. And we said many of the things that have already been said, and I think one of the issues around are these papers really focused on healthcare delivery systems as opposed to the broader issues of health. And I think that's where the patient individual issue keeps coming up, and I think some of the examples are more public health focused, yet it seems the focus is healthcare delivery. So it was just one of the comments as you look at these papers to really be clear about that and maybe even organize them that way. Another point was really, I think, for us, we really got stuck on the issue around health disparities. And I think, having one paper, we actually would like to open this up to the authors to really think in each paper what the issues are for diverse populations. Because I think that's so important, and I think, again, sometimes we sort of single it out and put it in one place as opposed to thinking about it broadly, and that was really a consensus.
I'm sorry, but I'm going to, in the interest of time, it is, I'm afraid, a little over, but just stay there because we may give you a chance for a response. Obviously, the applause, the interest meter went up on the health disparities issue. So I'm first going to give Dick a chance for a first brief response, and then I'm going to invite anybody else in the audience again to follow this thread just a little bit, to drill down this interest. So if you come, Betty, don't strangle me afterwards, but you may have something to say about health disparities, but I'm going to once again allow people, and then we are going to get to Betty next after that. But if there's anybody else that has something specifically to recommend or state, or if they want to get in the record about health disparities, Dick.
Well, I think, and this probably goes back to why some of the posters aren't multi-level if they're dealing with racial or ethnic groups, is that most people don't understand the difference between population health and determinants of disparities. In one case, you're talking about mammography is a good example. It improved the health. Everybody went up, but it didn't correct the differences between the outcomes for some people versus other people. And to think about that, you have to think about it differently to begin with. Ernie's comments, just to respond, it's not a zero-sum game in this. So if when you get a coalition together, you're going to focus on one thing and you're going to address that. Another coalition may focus on something else, and if they have the political clout, they're going to get it. So I think it's a mistake to think about that if you get a change in breast cancer, you're going to lose the chance to get someplace else. That's not addressing disparities. Addressing disparities is, I think, in most of the writers that talk about it, taking care of people who are at different levels in a hierarchy, social status hierarchy, because it's really socioeconomic. It falls away, as I pointed out. So I think that's the issue, and understanding that you're always talking about comparative effects, basically, and what causes the differences between those groups. If you focus on that, then you're talking about disparities. If you're talking about why African Americans don't do something or why Hispanics don't do something, you're maybe talking about population health, or you're maybe talking about cancer control, but you're not talking about disparities.
Okay, quick response if you'd like.
And I think we agree. I think the point is, though, to really, on each of the papers, as you look at those issues, to address that,
Right.
as opposed to only one paper. That was really, I think, our point.
Point taken. The committee definitely has it
And
down.
I may be a bit opinionated on that issue.
And Betty, at last, believe it or not.
I'm Betty Thompson from the Hutchinson Cancer Research Center. And really what I have to say has a lot to do with my work and our work on health disparity. But it was triggered by the comment that I heard from Steve Klausner, which was, let's not start, or we shouldn't start this work from scratch. And I want to talk just very, very briefly about the whole public health model. The public health model has been oriented all the time to working in a multi-level intervention format. We've always looked upstream to find reasons why people do what they do. We've always looked at social determinants of health. We've always looked at health disparities. And I think one of the things that we need to do coming away from this conference is recognize that we have a good bedrock on which to rest our activities. And I would personally like for the supplement to make note of that. I think it's important to recognize that we aren't starting a whole new thing. This is something that's been going on for a long time. And at the risk of, dating myself, and Russ is somebody who can respond to this, the old days of commit, when we were talking late 80s, early 90s, was a classic example of how we do multi-intervention research. Today, we have the CPHHDs, of which Dick is a part, and those are all multi-intervention components. So my point is really just to say it's not all something new. There are new aspects of this, but I want us to remember the history on which we're building.
Excellent point. Since you called me out among others, I'll see if anybody else wants to respond, but I'll point to the next to last comment here about international issues, and I think this relates to something Dr. Scott said yesterday, Betty, and it has to do with policy level interventions. And for me, one of the implications of what we heard him say is that as informative and important as it was today, Kelly Deaver's talk, I think, about the context of healthcare reform, that is critical. That's the dominant issue driving us. But we are one country. We're at one point in time, at one point in history. There are a whole lot of lessons from other people in the world that have other types of health policies and other contextual issues and lessons to learn from that as well. I don't want to put words in your mouth, Betty, and I'm trying to keep to my own 1-minute rule here, but I think some public health people might actually say or want to have a greater articulation of the thing about the patient requiring and saying the mandatory patient level outcome, even if you're patient-centered. I think some public health people might say, wouldn't building a healthier community, an outcome and index of that, be an equally valid, or at least address the crosswalk between those two? So, do you want to reply to that, or Betty? Nope. Okay, anybody else on the panel want to? Steve.
Just want to say a brief thing. I appreciate those comments on not starting from scratch. I think you said it much more eloquently than I did, but I was trying to convey some of the earlier things. I think even though we may think that there's a small number of studies, those studies are very, very important in helping us really get into granularity about how these things work, even in community health settings, that can help us think about this. And one of the things I think we've seen in some of the literature review is that the way these studies are presented in the literature, there's multiple publications that you've got to pull together to really get the story. And I think we've got to be a little creative to try to paint that picture a little more clearly in the way we go about trying to assemble that literature. And it's something I think we're going to take back for our journal articles.
Okay, we have 15 minutes left. We're going to get to these two individuals here who have been quite patient. Then I'm going to call out Tom Vogt, as well as anybody else that would like to respond to the issue about, or anybody from the VA. Becky isn't here. Maybe Martin, you'd like to take it from the VA, but I'm going to ask, what in particular can these organizations that have these state-of-the-art, at least for the U.S., electronic healthcare systems, what can we do, and in particularly this slide here on the right-hand side, how can that relate to the ubiquitous media and technology things, the social media, the patient engagement, where they're getting their things. What are the implications of that revolution and phenomenon? That's the other huge contextual factor that we're facing with our society today. So I'd like to call out Tom and Martin on that. I'll give you a couple minutes to think about that while we take these. And I forget who was first, Mark or Deb. Why don't we let go first?
Sure. So I'm David Hager from the Indianapolis VA at Indiana University. So I'm representing table 14. One comment related to this public health discussion I think that came up at our table that we came back to a few times was the idea that in these multi-level models that we are somewhat drawing upon a couple of different traditions. And so with one multi-level model going from the patient to the providers to the organization, it's more a health services research tradition. And then in another model, we're thinking from not necessarily to the patient, but the individual to the family to the community, more public health model. And so there's some integration or thinking how those relate that would be a helpful outcome of this conference. And I think one thing that causes them not to be as related as perhaps they could be is some of this issue of incentives in terms of, healthcare organizations aren't necessarily incentivized to address the health of the community in which they reside. They're more incentivized to address the quality of the people who come in through their door. So there's a little bit of disconnect there between population health and incentives of healthcare organizations. Maybe ACOs will get at that some, but maybe this is why these population health statistics it could be one of the causes for those poor health statistics that help frame this conference. So that's one comment. Let me also...
Very quickly.
Yeah, I think this will be a short comment. From the VA perspective, one question that I have coming away from this conference, and not necessarily an answer, but a question I'll ask myself more in the future, is how implementation science, which is something we've made a big commitment to in the VA, relates to multi-level interventions and how these are similar and different conceptually.
Thank you very much. Anybody response? Or just duly noted? Thank you. Appreciate your sharing that. David? Deb?
You asked what we would do when we went home.
I did, by Tuesday.
Okay, Tuesday. So by Tuesday, I'm going to email the head of our CTSI, and I'm going to bring sort of a synthesis of what we've covered here, along with some dissemination thinking as well, and I'm going to try to get some of this considered within our CTSI, because my sense about the CTSAs or Is or whatever they're called at our institutions is that they hit us with a roar in many places, and they are really, in a good or bad way, monopolizing the conversation about this topic in academic medical centers, and sometimes good, but sometimes bad, and we know things, people here know things that are not known by the CTSI or A folks. And so I was intrigued that I think the only speaker that mentioned this current system of delivery of funding and support in an institution was Moeen, and he's written a lot about this, but I think that maybe all of us should at least understand how the T1 through T4 systems work in our field and where they don't work, and sort of push back a little bit where they don't work. And that's what I plan to do by Tuesday.
Thank you very much. I would love to hear 30-second, we're now down to 30-second talks. I've got you, Moeen, here in just a second. But 30-second comments about what others of you are going to do, if I can find that, by Tuesday as well. And in fact, what I'll do is I think the CTSA is a pretty important issue, an opportunity. I agree with you. It's a train that's out of the station, but it still could be guided down one track versus another. So I'd love to hear if anybody has thoughts about multi-level intervention implications. I'm going to let Moeen respond to this, and then I want to engage Tom on this EHR, PHR, electronic health record. What's the key thing or two we can do with regards to electronic, Tom and Martin, health things. And then I'd particularly invite if anybody has anything else on CTSAs, but we're going to finish this by allowing, my math says, 45 seconds now for one key takeaway point from each of our panelists up here. So I'm giving you an early warning. So Martin, you get two. You get your response to Tom's on the EHR, and then the one other key thing that each of you heard in 45 seconds or less. Tom.
Well, to do this quickly, I'd like to spend a lot more time. But HMOs, particularly those with professionally autonomous research centers, which constitute the HMO Research Network, have spent many years trying to do research in that setting. They haven't always been honored or respected by their parent organizations, however, and the wonderful things they do have often not been implemented. However, in the process, the HMOs, particularly those in the network, have begun to develop EHR systems that look beyond the use of those systems for the provision of care, that begin to use those systems to learn from what we do. And that's resulted in a national virtual data warehouse that I mentioned yesterday that has over 15 million people in it. And we have a long way to go to make that easy and cheap to use, but it's usable. And that's what they need to do. They need to improve the uniformity of coding, the ease of data access, and ease of data pooling, and the quality of the data. They also need to participate at higher levels of management, particularly in multi-level efforts than they have been doing. I'd say there's some going on there. It's mixed. They are not acting proactively at present to agree to test more rational forms of care, that is, to reduce unnecessary care. I think because there's a fear of being perceived as denying care instead of doing things rationally. They need to support research at the implementation level. They've supported it at the sort of intellectual level, but they have been reluctant, not impossible, but it's very difficult to change care in the system, to do things differently. It takes an extraordinary amount of legwork and arm twisting and so on to get to that point. And finally, a point that you mentioned, Russ, regarding social media, many members, not all doing the same things, so I'll talk for Kaiser Permanente that I know the best, has begun actively to participate in interventions over the internet, and in fact have begun to design systems that are supposed to shift care from the office to the internet. And what they need to do with those is to evaluate them more rigorously and evaluate their cost effectiveness as well. And that to do that, they need to get involved with the researchers more. The researchers in these systems need to collaborate more aggressively with the university researchers, because we simply don't have the arms and legs necessary to take adequate advantage of the extraordinary data resources. I want to tell you, those data resources are beyond your wildest dreams if you're not familiar with them. You can dream great dreams and ask questions you haven't ever been able to ask before. You will also be frustrated and have problems when you try to use those data, but collaborate with these people.
Thank you very much. I think that was worth 2 minutes. So well stated. I'm going to offer one friendly provocative amendment to that. I would say that not only the HMOs, but most other healthcare systems that I know of, despite the billions that we've spent, despite the huge advances that we have made, have one glaring hole, i.e. patient-reported measures and outcomes, and how do those relate and not being collected systematically on a national basis. Now, the VA might be doing that. And with that, I will turn to Martin, and then we're getting about time for the 45-second one-point summaries.
There are other people in this room I know from VA who probably can say, things that are of more importance than what I will say. But I just want to point out two things about the electronic health records in the VA. We've been talking about them in terms of their research value. And in fact, one of the attractions 18 years ago when I moved to the VA was the ability to use these data. I mean, it was like a gold mine. But the other thing I want to point out is how the electronic health records and associated IT can be used for changing practice. And there certainly there is literature around things like the use of reminders, and other assists that come from the technology. So don't forget that side of it, which has also been used quite advantageously in the VA system.
Okay, we're going to start now, and we're going to end with giving Martin the last word. We're going to do our 45 seconds starting here, but when we get halfway through, we're going to pause for a final call out, but somebody that thought he was going to sneak out and is now non-attending like a third grader by the name of Kurt Stange, who is called out, and he is going to tell us what PBRNs in primary care is going to do by next Tuesday to advance the multi-level agenda, research agenda here. But I'll give him a minute and a half to think about it before he comes up. So, please start. Yep.
So I've been fascinated over the last day or so to learn more about multi-level interventions. I think they're extremely complex. I think they're very promising. But I remain unconvinced that necessarily moving in 3 different directions all at the same time is necessarily going to afford better outcomes than doing so through individual parallel efforts or serial efforts. So I would love to see a demonstration project that would prove the benefit of this to really put enough impetus behind it that we could actually change the minds of funding institutions, et cetera. So I'd love to see this whole concept tested in a rigorous manner to demonstrate that it's more effective, more efficient, et cetera, like we hope it is.
A CER challenge called out to the multi-level thing. Thank you. Good model. Win.
So can I get 2:45 seconds?
2:45 seconds. I'll give you 1 minute and 15 seconds.
Okay.
Last offer.
So one of the reasons I'm excited about this conference, and one of the reasons why I spend so much time traveling between CDC and NIH, is that I believe in the value of joining both a research institution with an action-oriented institution that's trying to solve the problems, not just trying to study them. So by definition, and here what I want to say is that whatever we call this, healthcare or health or public health, in order to attack a problem, whether it's smoking, obesity, or whatever, you need multiple levels. You need that from a solution perspective. It's just that the literature hasn't caught up with that idea. People are studying their one thing at a time in their own institution. I mean, public health, and I put that as a population health perspective that worries about disparities, worries about access, worries about everything, is trying to attack the problems from multiple viewpoints. And we don't have the scientific tools to do that. Healthcare is an arm of public health. So for those of you who think that medicine is a branch of public health, I'm with you all the way. And we're going to have to find a way to all get that science to back up the actions. So a few years ago, I wrote a paper called "Will Genomics Widen the Schism Between Medicine and Public Health?" And my thesis is that genomics provides us with an opportunity for the first time to take an inherently biomedical model and put it in the context of population health. Because with that, we might be able to finally bring that biomedical community and the basic science researchers to think like health services or public health people, to see the outcomes of all their technology, to see whether it will benefit but not harm people.
Thank you. That was worth 115, but now all my other friends are going to be mad at me because they don't get 115 too. Yeah, exactly. So, Dick.
Okay.
And Kurt, get up here.
My take-home point is that from what I've heard about the Affordable Care Act and all the other things, is that whatever interventions or innovations come out of these multi-level studies, one of the questions should be, will this advance or will it narrow the disparities that currently exist? And it's something that you do at the start of thinking about new things, not after you've done them, because by then the differences are too big to fix.
Well said. Okay, Kurt, and then we have our last 2 comments up here. What is primary care and the PBRNs and the Annals of Family Medicine going to do by next Tuesday?
One thing the Steves might want to do when the supplement comes out is send it to these different communities with a cover letter that tries to frame it appropriately. The PBRN community might look at that and say, the fundamental approach that practice-based research networks have is a community-based participatory approach, but we've been focused lately on just the practice community, and most PBRNs now are really trying to take a broader community perspective. At the same time, though, looking at the infrastructure for a lot of practice-based network research is really the information technology, the EMR kind of platforms, and the CTSAs are trying to work with PBRNs to provide that. So I think what PBRNs might do with this idea of multi-level research is say that the linkages that we've been trying to make are well set up to actually try to act on that idea. That we can't do it ourselves, and we need to partner with others.
Excellent. Okay. Martin, and then I see Martin just came, or Brian just came back in the room. Brian, we called you out earlier up here. So the question is, what's implementation science going to do by next Tuesday? If you want to respond to that, you have 45 seconds after you find your way to the mic, but we're going to go to Martin, and then Steve is going to close this session out for us.
So 3 points as quickly as I can. First off, I take away that the definitions of levels still are messy. I'm an optimist, so I come away with the glass more than half full. I think if we get 90% of the way towards defining what levels are, that will be very helpful. And maybe the next 10% we put off a bit. Secondly, and perhaps Brian can comment on this, is I think, this is a response to a question from the audience, I think that implementation science recognizes multi-levels, but I'm not sure when implementation science was in its infancy, if it really did, because there were a lot of studies that we saw that I think were single level. My third point is, really, as I reflect on all this as an organizational theorist, I think the concept we're dealing with is that of an open system versus a closed system. And you know, an open system is one where the boundaries are permeable, and in fact, in practice, in the real world, the boundaries are permeable. But the thing is, do we conceptually and in practice treat it that way, or do we treat it as if it's a closed system and we can operate in our little part? We can operate in our little part and ignore what's going on outside. And it's easier to operate in a system and treat it as a closed system, but you do so at great peril. And as us doing interventions, we do so at the risk of our interventions failing.
Thank you. And that tied right into the second point here about the complexity of the future in our situation, ignoring that at our peril. Brian.
2 20-second responses. The first is the journal will do what it always does, which is welcome and encourage submissions on the topic. The second thing I think is something we don't do often enough, and that is an editorial or commentary or other more proactive effort to identify issues and proactively seek out submissions, and that's something we'll talk about.
I want to thank all of the panelists here. I want to close with this one slide here that Einstein anticipated this conference 50-some years ago, as you can see there, that we can't keep thinking at the same level that created the problem for us in the first place. But with that, we are going to close with the words and the notion that Steve is going to tell us and explain in the words of Brian Weiner. He is going to explain at the bottom of the last slide the infamous and, the one and two, which that was the key challenge for the conference. So we're going to close with this session with Steve telling us about the and.
Well, I don't know about the and, but that clearly talks about connectivity. And I think that one thing that is, for me, that's important is just the moment I think we have right now in history to really have to almost be compelled to address these issues in some way, because I mean, Kelly talked about health reform, and Moeen talked about the tsunami of genomic medicine, but there's a lot of other things going on in the cancer care delivery system and the community health system that I think are major changes that no matter whether you want to define, you know, reminder systems that affect both patients and providers, you know, as 1 or 2 levels, clearly they're not going to be sufficient to address the kinds of pressures that are occurring given the expectations now with us reaching out to the community to try to get community engagement, not only in basic research with biospecimen collection, with clinical trial participation, and oh, by the way, providing patient-centered medical care. Those things are all happening now in kind of a perfect storm. And I think that the only way I can imagine having an opportunity to deal with this is if we really take a very systems point of view in terms of how these different factors interact with one another. And if it's not multi-level intervention research, tell me another game in town.
Thank you so much. And with that, that is the end of this session.